so this is a different case, and you see some chromosomal abnormalities. This is a tissue, not liquid biopsy. Next slide. And this is actually based on our software classification. This is pancreatic cancer, and or classified as pancreatic cancer, but not necessarily so, because if we don't really have enough in our database about cholangiocarcinoma. So all these will be lumped into pancreas for now, or we are lumping them into pancreas until we collect more cases for subclassifications for cholangiocarcinoma and other abnormalities. But this patient has overexpression of FGFR3, FGFR2, as well as you can really see here. Next slide. And if we look at mutations as well as the fusion, definitely this patient has a fusion in FGFR2. And in addition to additional mutations, as you can see here, the tumor mutation burden is low, but the FGFR2 is very relevant as a fusions for treatment, especially in patients with cholangiocarcinomas. Next slide. So this is the summary, and practically the most important clinical finding is the overexpression and the fusion. Dr. Coteras?
This is actually very helpful. Thank you very much. So this is a 71-year-old patient with quite a multifocal metastatic cholangiocarcinoma, just recently diagnosed in August 2019. So he went under surgical resection, was found to be metastatic. He went under a systemic chemotherapy with cisplatin gemcitabine, unfortunately progressed. Based on the results that we have in FGFR2 fusion, patient participated on a clinical trial with us with an FGFR inhibitor, which currently still on a study at this moment. Of importance, based on the 5102 clinical trial, FGFR2 from Incyte was approved just recently, called pemigatinib. The data is actually quite intriguing because 20% of the patients with cholangio can harbor this genetic alteration, with an overall response rate of 36% and control of the disease in up to 80%. Also, it's important to know that some of those patients has an IDH1 and IDH2 abnormalities, which also there are available therapies for them. So at this moment, also out of these genetic abnormalities, I frequently consider, even though the patient has a MSI stable and a low TMB, the fact that he has a BAP1, I may consider him for a treatment for immunotherapy down the line, depending what happened with the FGFR inhibitor inhibition.